Okay, this is a talk about cicadas. It's really a talk about the hard end of palliative medicine. Palliative care in cancer is easy compared to palliative care in neurodegenerative disorders. That's the first point I would make. The ancient Greeks were actually onto this, really. The myth of Tithonus, I suppose you pronounce it. He was the lover of Eos, and she wanted him to live forever. And she asked the gods for him to be made immortal, but she forgot to ask him to be eternally youthful, which is, you know, I think we'd all have this preference if we could get away with it. However, he lived forever. He became brittle, his mind deteriorated, his speech became a mere babbling. In other words, he became demented. But critically, Eos must have been a good woman. She didn't abandon him. She turns him into a cicada so that no one will fault his mindless chirping and fragile body. Okay. So this is really the apocryphal story about dementia. Sadly, some things have changed. So you all know what dementia is, so we don't need to go there. The life expectancy in dementia, there's a huge number of factors that actually influence this. I think the median survival time is probably lower than it used to be thought of. It's an incurable disease. I think that point's been made several times since I've been here. It's a terminal illness. But there's a huge number of factors that may well influence its life expectancy, including how old you were when you got it, what type of dementia you have, what stage it is, what other disorders you have, whether or not you're an intelligent person with good cerebral reserve or you are not. For example, you have Down syndrome, for example. What sort of social supports you have, how much you drink. It's shocking in my practice to recognise how much some demented patients drink. I'm absolutely appalled, actually. Healthcare access. So there's a number of factors, and that's the obvious graph, which has already been mentioned previously, the steady but incipient decline of dementia. So the sort of classical case that I come across is, you know, a very elderly lady with advanced dementia. Of course, she's had a fall, she's delirious, she's hyponatremic, she's been treated with this, but she's also had multiple other medical complications. She's getting into renal failure, she's actually got cancer somewhere, she's in chronic pain. She lies in the ward calling help, help. She's disorientated, she's hallucinating. All of these things have been tried, that Adam's been there and done all of the things that he does. And really, we're stuck with her. She's still in hospital. She's not well enough to go to a D6 facility. She's stuck in the assessment ward where she's been. Just to make the point that there are many types of dementia and many people have the misfortune to suffer those. I wonder if the current President of the United States has one of these, but I'm not sure. He's just extremely narcissistic, perhaps. That gentleman who's President of Russia was a very heavy drinker, for example. Robin Williams, of course, Lewy body dementia. Jacqueline Dupre, who was a cellist, multiple sclerosis. Woody Guthrie, Huntington's disease. That is Howard Hughes, who invented the diamond drill to find oil. He had probably chronic traumatic encephalopathy, not from playing rugby, but from crashing aeroplanes, which he used to do in the early days. It's said that Chairman Mao had frontotemporal dementia, and Rudolf Nureyev, of course, had HIV dementia. So, you know, depending on what type of dementia you have is going to significantly influence your course. And although we often used to say that all dementias end up similarly, actually they don't. And I think as we're finding out more about some of them, particularly, and I'll come back to Lewy body dementias, they're very different actually, and they're really challenging for us to treat. So what are the principles of palliative care of dementia, or dementia care generally? Mild and moderate, you focus on the quality of life and the maintenance of function and independence. And moderate to severe, maximise comfort, avoid aggressive, burdensome or futile treatments, and we'll come back to that. And preferably allow death to occur naturally. So what are the symptoms that people have in terminal dementia. I think Adam's was 90%, but I think probably in the advanced stages, I think everyone has some forms of behavioural psychological symptoms. Many are incontinent, of course. Many have pain. Many have troubles with their bowels. Most don't eat very well. Some are short of breath, aspirate, get pneumonia, pressure areas. So actually that list is incredibly similar to the list that you have with advanced cancer. I'm going to have a slightly different take on behavioural and psychological symptoms of dementia. Actually, I think they're misnamed. They should be behavioural and psychiatric symptoms. So if you look at the behavioural symptoms, and I think that Adam has mentioned all of these, maybe he didn't mention hoarding, which is quite a common behavioural, and culturally inappropriate behaviours can be very distressing for the culture that they come from, with their disinhibition, for example. And the more psychiatric ones, depression, agitation, delusions, hallucinations, and so forth. So if you look at the list, and that's a huge list, I concede, but I'll let you go through it really, but I think we've really discussed most of these. Fatigue, maybe we haven't discussed. You know, most people with dementia, if you go into a dementia ward any time of the day, half of them are asleep. It's really tiring when you have a brain that doesn't work properly. You've got to work extra hard for it to work at all, so you get tired really very easily. For example, apathy, as I mentioned, loss of appetite. Linguistic regression, people whose English is their second or third language, as they dement, they revert to what was their primary language. And that can be really difficult, of course, if their primary language is Russian, for example. Psychological regression, loss of independence, loss of immunity, I think. We've talked about sleep a bit. And then these other symptoms here, the more psychiatric ones: confusion, aggression, impulsivity, falls, disinhibited, catastrophic reactions. Those are the sort of organic equivalent of panic attacks, where someone is confronted with some problem and they can't solve it and they just freeze. They just don't know what to do. And they can have those walking down the ward. They don't know which way to turn and they can just stand there, for example, and then another patient comes along and hits them and so forth. Exaggerated startle is a common one that actually is often not written in the books. Sundowning, I think, just refers to the deterioration of all of these symptoms as the day progresses, or as they get tired or the night arrives. And the really difficult ones, particularly in the advanced stages, the rejection of care. You know, these patients don't like to be washed, they don't like to be fed, they don't like to be intruded upon, really, and that's a huge dilemma which we'll come back to later. And we'll come back to this as well, an enhanced will to live, despite their apparent deterioration. I'll come back to that later. So the philosophy of clinical management at the bedside, and I think this is generalised, and I really just want to focus on, you know, as medical practitioners, we identify symptoms and then we try to formulate a process to account for the symptoms that the person has. Why have they got polyuria when they're in renal failure, for example? And I think we need to apply the same to dementia care, really. Investigations, and the question is, when do you stop investigating in modern medicine? And then we intervene if at all possible. And I'd like to go back to Jackson, famous British neurologist 100 years ago, who's presented us with the doctrine of dissolution. In other words, that the nervous system is reliant upon evolutionary principles. And then when you get damage to the nervous system, it tries to readapt, but at a lower and more simplistic level than it was functioning before, in order to maintain homeostasis. So that when you get damage to your nervous system, more primitive functioning is released. So you get compensatory or positive symptoms, but you also have negative symptoms. And contrary to what Adam would say, I think it's easiest to try and simplify the neuropsychiatric symptoms to symptoms of loss and compensatory symptoms. So the symptoms of loss are all those ones on the left hand, this is the same graph as the same slide as the other one, but with the symptoms of loss and compensatory. So these are all the loss symptoms. This is what happens when your brain fails. And this is what happens when your brain fails and it tries to compensate for what's been lost. Okay, and if it's a much more simpler, it's the idiot's guide, I think, to neuropsychiatric symptoms of dementia. But I think it's sort of simple, and I'll show you how it is in some ways useful when it comes to trying to manage some of these symptoms. Actually, here's Adam, and I've just been simplifying your concept, Adam, of neuropsychiatric symptoms. But I'll talk about it later. Although I'll just go back to say that it's really based on Hewlings-Jackson's work, if you know Hewlings-Jackson. Okay, so if you just divide them into symptoms of loss and compensatory symptoms, sometimes that's easier. The aged and damaged brain doesn't have the plasticity to allow it to anatomically or functionally repair. So that when you have a brain injury in a young person, sometimes the brain's clever enough to evolve different neural pathways to overcome what the loss is. But that doesn't occur. Well, it occurs in the early stages of dementia, but as dementia progresses, as Adam's diagram showed, it loses its ability to have any plasticity. It has no reserve left. And so that essentially this means that trying to treat the loss symptoms or reverse the loss symptoms is absolutely futile. You can't, because there's nothing there that's going to allow the brain to overcompensate or function for the loss. So when it comes to managing loss symptoms, and I think all these things have been sort of said before, there's nothing you can do to change them. You've got to apply supportive care measures, environmental care and education and support of the family, the people who look after the patient. And pharmacotherapy is really limited because there's no neural substance, there's no neurotransmitters left to work on, so that it's pretty useless. Obviously, it's useful to try and get rid of all the other medications that the demented person's taking for their hypertension. And we know that the natural history of hypertension is that blood pressure tends to fall with increasing age. So most of them are on antihypertensives that don't need to be, or statins, for example. Maybe thiamine for alcoholics is useful. Question mark, I agree with what Adam said about melatonin, the jury's out. But essentially, cholinesterase inhibitors are useless at this stage. And psychostimulants are useless too, because there's no dopamine left to work on. So that essentially for the loss symptoms, pharmacology is not going to work. So either don't introduce it or withdraw it would be the message coming out of that. I guess this in cancer palliative care, we quite often see what we call the lawnmower effect. Just before people die, they go through a phase of enhanced alertness and cognitions, really, and then they die. This never occurs in dementia because they've got nothing left to overcompensate for, so that we don't see that in dementia. And we unfortunately don't see it in cancer care so much these days, because mostly they're on benzodiazepines and other medications that complicate that process. So how do we manage the compensatory symptoms? Well, obviously all the things that we were doing before, and preventing, if they're wandering, trying to prevent the falls, really difficult. Do you immobilise people with benzodiazepines and then you increase their falls risk? How do you provide supervision every moment of the day and night? Really difficult. Attentive nursing care, well, that's ideal, but there's huge pressures on nursing staff, and they can't watch 20 patients every moment of the day, so that can be difficult. Obviously, treating, if they have a delirium, treat it, and there's also some work from the delirium field where there's some possibility that prophylactic antipsychotic medications can raise the delirium threshold, and so a person's less likely to have a delirium. that's sort of a bit questionable at the moment. Sometimes with compensatory symptoms, then pharmacology can be useful. For example, major tranquilizers for psychotic symptoms, maybe for aggressive symptoms, maybe the SSRIs or antidepressants for agitation, mainly hormones, and SSRIs for sexual aggression, the latter just causing sexual side effects which you take advantage of. If they don't occur, they only occur in 40% of your patients, so that's not invariably successful. Maybe opioids and benzodiazepines for agitation, but as I think Adam has said very clearly, pharmacology, and certainly in the late stages of dementia, is of questionable clinical benefit. One would assume that people at the end stage of dementia suffer a lot. It's really hard to research that. Actually, there is one Israeli study that would suggest that it's a high rate, but then another Dutch study which suggests that actually 50% of people, according to their relatives with dementia, died peacefully. And I think that's probably right, but it still leaves you with nearly 50% who don't die peacefully, which is the issue really. Dame Cecily Saunders, who sort of founded palliative medicine from an oncological perspective, how people die remain in the memory of those who live on. And that's terribly relevant, I think, in dementia care, where the terminal phase can be long, protracted, terribly distressing for the relatives to observe, let alone for the patient. The clinical course of advanced dementia, well, it's actually about the same as metastatic breast cancer. It's not good. 50% die within 18 months. The question is, we'll come back to that, what they die of. The probability of pneumonia is quite high, of fever is quite high. As I mentioned in the loss symptoms, I mean, I think they get problems with immunity, and they're much more prone to getting infections, but also that also relates to their personal care or their lack of personal care and so forth. So the mortality in advanced dementia is is very significant, really. And although we don't often associate it with oncological palliative care, you know, the prognosis is similar, really. What are some of the predictors? Well, these are fairly obvious. When the person can no longer walk, when they can no longer converse, when they're entirely dependent on the nursing staff. Cachexia occurs as part of advanced dementia. Patients lose weight irrespective of what you give them in terms of dietary supplements or food. Recurrent infections, pressure areas, hip fractures. It's inevitable for many patients, and pneumonia, of course. What are the signs of dying with dementia? Well, deterioration, reducing responsiveness. You find that they sleep more and more of the day, actually. Unfortunately, some sleep during the day and awake at night with their sundowning, and that's a major clinical problem when you get the reverse sleep-wake cycle. Increasingly bedbound, you know, they don't look well, they don't eat very well, and obviously towards the end they chain stoking and so forth. I think someone alluded to this earlier, really, that in the advanced stages, you know, demented patients need total care, really. It's very hard to communicate with them. They can't ambulate. They can't even be independent. They can't relate in any sort of way. And they have primitive reflexes like the startle reflex, which I mentioned before. So what are the causes of death in dementia? And invariably on the death certificate is written pneumonia. But actually I think the commonest cause is inanition, which has been called various things in different communities, really. Gainig, I suppose it's pronounced, is an Israeli or Jewish description. That's a German one. Vital exhaustion is something probably out of the Netherlands. But I think that this is caused by loss of neurons in the basal ganglia and the brainstem, and sooner or later the respiratory and cardiac systems just shut down really. And I think invariably by then, because as that's happening, they are also likely to get a pneumonia, and it's sometimes simpler just to put pneumonia on the death certificate, but I don't think that's particularly accurate. Some die not of starvation but of cachexia. Some die from their falls. We make medical mistakes and that kills a few. Some die of self-neglect and suicide, which I'll come back to. Where do they die? Well, they used to die at home and now they die in institutional care. And that's a huge issue for modern medicine really, and for the hospital system in general. See, in the 80s, 25% died at home. In the 90s, it's down to 15, and probably it's even lower than that now, I would think. More and more are dying in residential nursing homes, which is why there's been a push over recent times for palliative care services to attend to patients within nursing homes, residential cares. A lot die in hospitals, but when you add up the institutional care, 3/4 are dying in public institutions or private institutions. So that puts pressure on those who work in these areas. It probably takes a bit of pressure off the GPs because they're not dying at home. So that's the only good news probably from a general practice perspective. So those are some of the points, and what I want to do with the rest of the time is really talk about some of the controversies in advanced dementia, and I don't have the answers here. Hopefully you do. So when do people with dementia die? What's your definition of death? You know, the sociologists would say that when socially he's already dead, though his body remains biologically active. You know, they would say that once you lose contact with the society that you live in, you're dead. Medicine has a slightly different view because we're more inclined to think you have to wait till you're biologically dead. When do you lose your personhood? Again, it's a sociological. So there's a clash, I think, between what sociologists would say and what we might say in medicine, where we're more biologically orientated.
And also what relatives might say.
And what
they'll say
relatives
something
would say.
like, I lost my dad 5 years ago.
Absolutely, absolutely. So, you know, this has huge implications, I think. But bear in mind that these are the views of us, not the patient. And that's one of the troubles I'll come on to. Can you die with dementia and dignity? You know, by the time people have advanced dementia, they've lost a hell of a lot, if not everything, including their autonomy. They're probably socially dead, as we mentioned, and they're probably in institutional care. So I do wonder if dying with dementia and dignity is an oxymoron, really, from our perspective. But again, is that the perspective of the sufferer? We know that delirium, the more episodes of delirium you have, the more severe your dementia becomes. When I was a medical student, we were taught that, you know, after an episode of delirium, you know, you recover, providing you don't die of whatever's causing the delirium. But now we're increasingly aware that actually delirium causes brain damage, and every episode an old person has, particularly if they're already compromised with dementia, every time they have a high fever with a urinary tract infection, they're delirious, they knock off a few more neurons. So that delirium is a very strong factor for dementia and cognitive decline in the elderly. So I mean, I guess it's, as Adam said earlier, it's another talk, but you know, we need to be treating delirium very aggressively. We need to be identifying it, managing it really well, and that includes in the community as well as in hospital. And I don't think we do that very well.